I really believe that we now have sufficient evidence to show that starting high-efficacy drugs from the very beginning is better, leads to better results than starting first with a moderate-efficacy drug and then switching to a higher-efficacy drug if this drug fails. So except for patients with what I'd call very mild disease, so without any bad prognostic factors, very few lesions, a mild relapse, so patients maybe that are still in a CIS or a RIS, most other patients would benefit from being treated with high-efficacy drugs. And we have now very good drugs, and the most important point is that we shouldn't be afraid of these drugs. We now have sufficient evidence as well to show us that these drugs, even when used in the long run, they are safe to use and they don't lead to any serious concerns, at least for 7, 8, 10 years that we are seeing now. So my recommendation to my colleagues would be that we should consider using more of these high-efficacy drugs earlier in the disease course, particularly for those patients that have one or two, at least, bad prognostic factors, and we shouldn't be afraid of using them because they seem safe and they lead to better results.